All right, so there's a lot of data to cover with this, so I'm going to go relatively quick through the slides. These are my disclosures. So I'd like to talk a little bit about the road that has led us to total neoadjuvant therapy, or TNT, as I'll mention it throughout the talk, indications and outcomes of adjuvant and neoadjuvant chemotherapy for rectal cancer, and what's the current status and future directions of all these components in locally advanced rectal cancer. So over the last couple decades, these are the improvements that we've seen with regards to the care of patients with rectal cancer. Started off with doing precise surgery, perfect imaging in order to especially evaluate the circumferential resection margin, evaluating our resection and assessment of the histopathology as well as tumor biology of these patients. Then came in the neoadjuvant therapy, starting with short course radiation, then longer course, and adding the chemotherapy, and actually studying this well to give it before or after surgery. And most recently, as we see more and more centers of excellence, the component of multidisciplinary care is quite important for these patients. The general concept for stage 2 and 3 rectal cancers is that the options of long-course chemoradiotherapy or short-course radiotherapy alone, in general, decreases the local recurrence rate by 50%. But I think we have to dissect this a little bit more than just saying, well, okay, it decreases it by 50%, and we are down to single-digit local recurrence rates, but we're seeing an increase in distant metastatic disease. So let's talk a little bit initially about the benefits of neoadjuvant radiotherapy, and these are just randomized controlled trials of TMA with and without radiotherapy. The first trial was the British-Canadian trial, included almost 1,500 patients. These included stage 1, 2, 3, randomized to short course radiotherapy or surgery alone, and then patients with a positive circumferential resection margin had selective post-op radiation. There was a statistically significant difference with regards to the 3-year local recurrence rate, and in the patients you can see that had a negative circumferential resection margin, it was even more important or more pronounced. And the 3-year disease-free survival was also statistically significant. So there was an impact even with a short course radiotherapy versus surgery alone, and this was TME. Because there are trials that weren't specifically designed with total mesorectal excision, and these were excluded from what I'm going to talk about. Then everybody knows about the Dutch trial when they have updated 10-year outcomes, almost 2,000 patients. They did include stage 1 patients, short course radiotherapy versus TME alone. And you can see in the patients, which was the great majority with negative circumferential resection margins, there's a statistically significant difference in local recurrence, and especially those patients with stage 3. But you can see the differences in stage 1 and stage 2. And this has really set the platform for not using radiotherapy for the earlier stage, at least T-stage rectal cancers. The overall survival was not significantly increased in the radiation group in these patients, and for the stage 3 patients with a pathologically confirmed negative resection margin with TMA alone had a 10-year survival of 40% compared to 50% in the radiation group, and this was significantly different. What about the impact of improved imaging? A lot of us are doing more and more MR. There are selective cases where we continue to do endorectal ultrasound. The Mercury study was published quite a bit ago, and there's updated results on that as well. 374 patients, briefly, 65 had stage 2 to 3, so the majority were earlier stage, and you have to consider this for the analysis of their results. 19 patients received neochemoradiotherapy, and this was for a circumferential resection margin less than 1 millimeter. Pathology confirmed the predicted negative circumferential resection margin in 97% of patients. Very good imaging study. But again, we had very well-trained radiologists evaluating these, mainly Gina Brown. And you can see the local recurrence being low like that, and comparable 5-year overall survival and disease-free survival. I guess that table didn't come out the way I wanted to, but let me just... So the table down there was mainly representing that the patients that had end nodal status positive, or especially that's the trial that first started with extramesorectal venous invasion that was highlighted as a risk factor for decreased survival and increased recurrence. The German Occam study was published last year. This is a prospective multicenter observational study, T2 and T4 tumors with any N or M status. Almost 600 patients. For the patients that had mid to low or less than 1 millimeter from the mesorectal fascia, and all the T3 and T4s received chemoradiotherapy in the neoadjuvant setting, and the other ones underwent TME alone. The negative pathologically confirmed circumferential resection margin was 97% in the TME alone, so this is even better than previous Mercury trial. And obviously, it's comparing apples and oranges of the patients that received neoadjuvant chemoradiotherapy just because they were worse players and obviously they were more aggressive tumors. This study did not include tumor biology as part of that or response to neoadjuvant therapy as a predictive marker for oncologic outcomes. So the pathologically confirmed circumferential resection margin that was negative was predicted in 98% of patients. MR is a very good tool. It highly depends on who's reading it too. This is just the 60-month median follow-up that was recently presented, 3- and 5-year local recurrences, as you can see there. No differences between the two arms. Not that I'm comparing those. There are different types of patients and tumors, obviously, but this is just representing that with an MRI, even with patients with locally advanced disease, it's a very good tool to place these patients in an algorithm of either receiving neoadjuvant therapy or surgery alone. And you can see there was a statistically significant difference in distant metastases, especially in the TME alone patients. This is also just the 3- and 5-year disease-free survival, also statistically significant. And what was good about this German, the nice thing about these German trials is that patients that completely refused neoadjuvant therapy, they still followed them. And you can see the local recurrence rate up to 14%. These are the patients that said, well, I know I have a bad tumor. I know you indicated neoadjuvant therapy. I'm not going to do it. I'm just going to go for surgery alone because I don't want, et cetera, of the functional issues afterwards, or they just refuse overall chemoradiation. And they did follow these patients, and it was a small group, but you can see the 14% recurrence rate, which is not horrible, but obviously 14%, if you're one of those, you're in trouble. So the take-home points from this is that pre-op imaging is key, especially for your circumferential resection margin. TME alone is associated with higher local recurrence rates than when those are achievable with preoperative radiotherapy, especially in patients that have end-status disease. And there's no randomized controlled trials comparing long-course chemoradiotherapy before surgery with TME alone. So the unanswered questions that I still have after reviewing this is that what rate of expected local recurrence is acceptable nowadays? Is there an imminence of overtreatment with most of these patients, especially in those who do not get preoperative imaging? And does the neoadjuvant paradigm delay systemic treatment, especially that we're seeing more and more distant metastatic disease? So that's what TNT really kind of falls into this whole game. It's well known from the 2004 German randomized controlled trial that the administering chemoradiotherapy in the neoadjuvant setting it's much better than postoperative, obviously. And overall, the whole treatment paradigm of rectal cancer with neochemoradiotherapy with TME and then adjuvant systemic therapy has been the standard, but it's really not evidence-based, and we're going to dissect this a little bit more. And these are kind of the points that I've been mentioning throughout the talk, especially emphasizing an increased rate in distant metastatic disease in patients that receive even neochemoradiotherapy. So if we just look at adjuvant chemotherapy in rectal cancer alone, it's not well studied, mainly observational studies. The optimal time interval in the drugs are really not well studied. We don't have results on this. This is a combination of 3 trials, mainly observational from Europe and the United States, showing no statistically significant difference with regards to 5- or 10-year disease-free survival in those patients that received observation versus adjuvant chemotherapy alone. So no, and that was the early experience in the 2000s. There was a very well done European trial, the EORTC 22921, over 1,000 patients with T3, T4s, good follow-up in these patients. And the main thing to emphasize from this is patients that received, this is looking at local recurrence and distant metastatic disease, and they divided them up in the patients who received radiotherapy or chemoradiotherapy in the neoadjuvant setting, and then further dissected them through no adjuvant or adjuvant chemotherapy. And really, where you really want to emphasize this in this group, the patients that received adjuvant chemotherapy and chemoradiation, which is typically what we do in the United States now if you're not getting TNT. And then when you look at the 10-year long-term survival, 34% risk at distant metastatic disease at 10 years and 11.7% local recurrence at around 10 years. This is a trial that was performed through the NCDBA database, almost 13,000 patients, stage 2 and 3. About a third of these patients received adjuvant chemotherapy. There was an increase of its use from 23 to 36% over the course of the trial. Good median follow-up in these patients. These are the states that actually did well, and you can see kind of the Midwest is around here. I like to emphasize Dr. Chang down here. No statistically significant. difference in that. But when they looked at the actual outcomes with regards to survival probability, and this is an outcomes thing, and there's a lot of selection bias, obviously, in this, but there was a significant difference in survival probability in the patients that received adjuvant therapy with a 10-year median follow-up. Roughly, adjuvant chemotherapy in rectal cancer, 21 randomized controlled trials, over 16,000 patients. When you look at all this together, a significant reduction in risk of death among who patients received adjuvant chemotherapy, reduction in the risk of disease recurrence in these patients, but there's really no data on oncologic outcomes per TNM stage, the toxicity of this, how many patients actually completed therapy throughout these trials. So after reviewing all these, it's conflicting data. So if you would like to contribute more to this, this is a good area for residents to actually look into. What is consolidation chemotherapy? So we said, well, we're waiting all this time after radiation. Why don't we sneak in a couple of cycles of chemotherapy? It's not going to hurt anybody, and maybe they'll have better outcomes. There's a multi-center phase 2 trial, including 259 patients. They received radiation with 5-FU, and then they decided on giving different cycles of FOLFOX, 0, 2, 4, 6 cycles after, during the waiting phase, and then TME 6 to 8 weeks after chemoradiotherapy. Adjuvant chemotherapy recommended to complete a total of 8 cycles in general of those who didn't receive anything or lower doses. They had, this is their follow-up. And then in general, when they looked at completion of it, obviously there's looking at 4 groups according to the 0, 2, 4, and 6 cycles of FOLFOX. So what did they find in general? Pathologic complete response was probably the biggest thing that they saw. So this is for group 4. This was the major game changer. Up to 38% of patients that had resected had a pathologic complete response. When they looked at toxicities, there wasn't a difference. These are the demographics on the right. But in general, when they looked at the toxicity, giving more chemotherapy during that waiting phase didn't increase the risk of their postoperative complications, which was reassuring. This is, again, the same Garcia-Aguilar trial. When they're looking at, going back to this, when they're looking at disease-free survival, you can see the differences with regards to their YP-TNM stage after surgery. This is survival, disease-free survival, especially between the patients who had a pathologic complete response. I think this is pretty well known nowadays. And again, the disease-free survival, a statistically significant difference of those patients who received up to 4 to 6 cycles of chemotherapy during consolidation. Again, showing a significant difference in those who got that. So in neoadjuvant chemotherapy with selective radiation, what are we doing with this? This was initially started by the MSK group. Their initial experience included giving patients FOLFOX up front. Patients that had stable progressive disease went on to have radiotherapy, and the responders just went straight to TME. All 30 patients, or 30 of the 32 patients, completed preoperative chemotherapy, all had tumor regression and TME without preoperative chemoradiotherapy. This was the initial report of up to 25% complete pathologic response, and you can see the local recurrence and disease-free survival there. And all of these patients had an R0 resection, which was the most important thing. Because of time, I'm just going to mention this really quickly. The GRECCAR trial, which was prematurely terminated, it's a multi-center French trial of 200 patients where they gave different strategies of neoadjuvant chemotherapy and selective radiation of good and bad players with rectal cancer according to MRIs. And the primary outcome was an R0 resection at 7 weeks. We can't really say much of the results of this trial except for some of the patients that received chemotherapy up front had actually better short-term outcomes from an oncologic standpoint. These are just patients that had carcinomatosis, which were like minimal in this group, and then R0 resections was 85% in the poor responders, which I guess the main thing from this is the rate of transformation from positive to a negative circumferential resection margin was 93% in those who received aggressive neoadjuvant therapy. This is the TNT experience from MSK most recently, almost 1,000 patients. This was their initial experience on how they kind of dissected down to the TNT patients. And you can see of those 811, 410 patients received total neoadjuvant therapy. I'm not going to go through the design of it. We're going to focus mainly on the results. The responsive treatment was very good in these patients. And the main thing to look at is that going through the table on the left side is that there was statistically significant difference with regards to the tumor characteristics. So it's not valid to compare patients from a selection bias standpoint. I'm going to finalize with talking about the Chinese FORWARD trial, the multicenter open label phase 3 trial, 3 groups of patients, almost 500 patients. You can see the schema here of radiation alone with TME versus FOLFOX 6 to 5 cycles or giving it after the TME. These are the comparisons of essentially the demographics from a cancer standpoint. And when they look at the results, it's hard to read if it's coming up on here, but the chance of an R0 resection was above 90% in these patients. They had very good outcomes with very little toxicity with upfront chemotherapy. And their PCR rates, where you can see the 3 groups, which was 5-FU radiotherapy, the FOLFOX upfront, or just FOLFOX alone, up to 27% of complete pathologic response in the group that actually received total neoadjuvant therapy. This is their follow-up, 3-year disease-free survival. There was no statistically significant difference with regards to that. And when they looked at local recurrence at 3 years as well, no statistically significant difference. So the main take-home point is that, so when should we be giving the chemotherapy? Starting off with chemo after radiation or during or after the actual TME, and giving them before and after the radiation made no difference in this randomized control trial. I'm going to advance to the next one. This is I know we're short on time here, but this is the recently presented multicenter randomized phase 2 trial regarding TNT. And it's interesting to kind of look at this pick the winner design. It's essentially looking at patients that have good response, and depending on what kind of response they have, they either go to chemotherapy or chemoradiation. And it was based on a PCR of achieving up to 25%. In the 2 groups of 311 patients, they gave them induction chemotherapy with 3 cycles of FOLFOX before their chemoradiation, or they gave them consolidation chemotherapy, which consisted of FOLFOX times 3 after the chemoradiotherapy. These are the demographics with regards to the tumors. When they looked at toxicity, these are about a third of patients had toxicity, more so in the patients that received the chemotherapy up front. The completion of induction or consolidation chemotherapy in Group A, 92%, 85% in Group B. So it was more in the patients that received the chemotherapy as a consolidation. And the longer interval between completion of chemoradiotherapy and surgery did not increase surgical morbidity in these patients. They overall saw a complete pathologic response of 17% versus 25%. And these are the TRG stages dissected out through those patients. So in general, that German trial actually showed that giving the chemotherapy as consolidation in the waiting period after giving chemoradiotherapy is probably better for achieving a better pathologic complete response than giving chemotherapy first, then chemoradiation. Someone has looked at the cost of this, and in general, for stage 2 and 3 rectal cancer, there is a cost effect to regards to giving it up front, especially in those patients that have complications afterwards or do not receive therapy when they look at actually days off. So it is a cost-effective intervention. These are the 2018 NCN guidelines. You can see chemotherapy is a part of these guidelines, and we're still waiting for the prospect trial results of this, and hopefully in the next couple of years we're going to have this. So how can we better define this? I think the future is going to bring us individualized neoadjuvant strategies, and this is going to be dependent on tumor location, biology, what we can assess with an MRI, the tumor response. I think it's very important to actually record this, and the toxicity to chemotherapy and chemoradiation. So in conclusion, TNT is safe and has significant advantages. It assures treatment of lymphatic and micrometastatic disease, especially with an increasing distant metastatic disease on the horizon with rectal cancer. It improves tumor response, especially PCR, and if you have a watch and wait strategy at your hospital, this may increase it as well. improve disease-specific and overall survival, and does not appear to significantly increase toxicity or postoperative complications. The disadvantages that I would like to leave with you is that, are we over-treating all these patients? So should we be giving everybody chemotherapy? And I think we're going to talk more about that in a little bit. And there's no long-term prospective comparative studies with regards to total neoadjuvant therapy. Thank you.